Hello. Sorry, I'm running 4 minutes late today, y'all. Mr. Midwife, are you already here today for me? Or is this old? I don't know how to. Okay. Welcome. My name's Bree. If we haven't met yet, I am an RN, NP, mentor, interview strategist, content creator, and I like to do these get ready with me's once a week. My intent was to kind of talk about just kind of off the cuff stuff, sort of the same stuff I talk about on my website and on TikTok and YouTube, and that is a combination of both professional NP stuff and educational stuff, and I'm ICU, so it tends to be a lot of ICU stuff. So I've been trying to stay on track with what my weekly blog is talking about, but because I've been such a slacker lately and have had interruptions, I'm not exactly on par. So to try and get things back on path, this week I am talking about nurse practitioner salaries, everybody's favorite. Money, money, money. Super important, makes the world go round, something you need to be considering when you're looking for a job. So we're going to talk about that, but it's not a ton of content, so I don't know if it'll fill up this whole hour. By all means, jump in with anything you have to say, questions, comments. I know, imagine that. I need really like a clone. By the way, if you guys haven't met Mr. Midwife yet, and I don't know if you, okay, so Mr. Midwife has a YouTube channel. It is entitled Mr. Midwife. I highly recommend you go check it out. He talks about all things pregnancy, mommies, babies, delivery. And it is what I like about his stuff is it is very easy, user-friendly for the layperson as well as the medical person. And for someone like me who knows nothing about mommies giving birth, it's very interesting. Of course, my mom was a midwife. I say this on, I think, every single live I come on. But anyways, okay, that's weird. But I don't know, Mr. Midwife, if you prefer to be known publicly as Mr. Midwife or if you want me to call you by your name. I realized that after the very first live when I said your name, maybe you don't want it said. So that's why I keep referring to you as Mr. Midwife. But if you guys don't know him, please go check him out. I have to use small words. They're all I know. Same. And oftentimes I pronounce them wrong or I completely misunderstand the word, like hubris, which my colleague told me one night I was saying wrong. I've been saying it wrong my whole life. You know, it's the wisdom we impart, not necessarily how we say it, right? Mr. Midwife is cool. That's cool. All right. Usually Nurse Scott is here with us too. Nurse Scott is an ER nurse. I don't know if he's going to show up today or not, but he also has a YouTube channel. He is interesting one to follow. He is in the early phases of his FNP journey, so definitely check him out as well. I'm having all these like amateur hour moves here. Lost my janky. This probably sounds really weird. Hold on. Hold, please. I broke my microphone. See, real professional here. We'll text him. I know he's in the middle of like starting clinicals, so his life has probably gotten real. What the heck, y'all? I may just have to like. Honestly, I broke this thing like a couple weeks ago, and I've been just like rigging it. Maybe I'll do like so. The other thing is I don't have readers on. Oh, well, that's interesting. Hopefully it'll work. Okay, so anyways, yeah, so go check him out. We all met through Nurse Liz, who I'm sure many of y'all already know. She is real famous, FNP, one of the kindest human beings you will ever meet. And she hosts a weekly live that includes a lot of people from the nursing world, all different walks of the nursing world. And she talks about hot topics, sometimes hotter than I can handle. And they're always on Fridays, which is hard for me because it's usually my post-call day. So I have to decide if the topic is something I can talk smartly about because fatigue and smart don't go hand in hand. So, you know, I have to really consider it. I know, Nurse Liz. Liz is amazing. Absolutely amazing. By the way, if you're watching this after it's been completed and you're watching the replay of it, if you will, you have to hit the button down below that says chat or live chat to see these chat messages. Okay, so salary. Y'all, I just made a formal YouTube video about this. Hey, Scott, where I talked about, I did a ton of research and wrote an article about the research that I found about nurse practitioner salaries because I think there's a lot of confusion out there. It's super It's super weird to me. Like if you go in and type a Google search, how much does a nurse practitioner make? You're going to get really weird lists. And it's almost like something that's been curated by AI. It's almost like Chat GPT has written all of these lists because they make no sense. They're not grouped in any way. And so it's confusing to my brain, which maybe it's just me, I don't know. But like you open it up and it'll have multiple different types of APRNs. It'll have it'll have some of it will be driven by specialty or subspecialty, and some of it will be driven by certification. And so it's like, how does that help you when you don't know how much nurse practitioners make and you're trying to make these decisions about whether or not you're going to get return on investment if you go back to school and all these kind of factors. So I made my own list. I made two lists in two different categories. One is from a broad perspective of different types of APRNs by certification. So the field of study that you're going into and where that kind of ranks, and there's 10 of them. And these are just, I didn't put any numbers to them. This is just like an overview, of like which ones are the most income generating and which ones are the least income generating. And some of these really surprised me. And then the second list is more specialty based. So based on exactly the population and the role in the population of people that you want to treat, where it ranks. And I looked at national numbers and came up with an average, and I looked at local numbers. I'm in the Southeast in Georgia. So I found it very helpful to compare all the Georgia trends, because even if it's a range, I can kind of get an idea about like number 1, how they compare with like number 8 regionally versus nationally, the numbers may be all over the place. So I made this and just posted this video a couple of days ago, and it's already been viewed 10 times. And I've actually had several of my friends reach out to me and get Nurse Scott merch. You have merch? What merch do you have? I didn't know you had merch. I don't have merch. I can't handle anything else, y'all. I got too many things going on. Certainly can't be merch. But if I did, it might say something like, I don't know. I tried to pronounce the word entrepreneur, and I still can't say that word. So maybe it might say entrepreneur woman with like a Southern accent at the end. Or maybe it'll say ADD rocks. I don't know. What should it say? That's awesome. He has lots. Get some. What do they say? They say your name on them? What is it, like mugs and cups and things? That's fascinating. Are you generating income from it? That's what matters. We're not here for that. You're not for the, oh gosh. Okay, so salaries. Focus, Brianna, salaries. All right, so I told you the background on why I did this research, and there are a few caveats I gotta say though, and this applies to both of these lists, and that is this. Many factors impact these rankings, some of which is years of experience. So most all of the numbers I looked at, none of them really specify whether it is a new grad pay or whether it is someone with experience. So I don't exactly know where these numbers fall. In my own personal story, I find that what I'm seeing out there is less than what you make with experience. So maybe add on another 20%. I don't know. The other thing is, I don't know if these numbers really include like shift differentials, if they include bonuses, if they include PTOs. There's a lot of extras as an NP that you get that you don't get as a nurse that you should be negotiating. All of those things plus CME. That's conference money. So you need to do continuing education in the provider role. You have to. And so most organizations will give you a pretty hefty stipend to go to these conferences. And some places get a lot of money so they can travel pretty far to cool places and really meet some interesting people and learn a lot. So there's a lot of extras that add on. I know I'm on salary too. They break it down by hour, but it's like, if I stay late, I don't get paid anymore. I think most NPs are on salary. In fact, I'm trying to think about it. Maybe, I don't know anybody who's not on salary, but some of them will have like a low base salary and then they'll have RVU bonuses. So that's revenue value unit. So however many, it's basically a productivity bonus. So if you see beyond a certain number of patients per day, I know it's very common in urgent care to have that kind of thing, then you get X number of dollars for each one that you see. So I think that these numbers I generated are all like base level, entry level, basic, no extras. So that's just part of it. Yeah, locums are definitely hourly, and they make a lot of money. So that's one factor. The other caveat is the region-specific needs, right? You're going to make a whole lot more in remote Alaska than you are in Atlanta, Georgia. You just are. And that segues into another caveat, which is supply and demand. So whether it's the region you live in or the specialty that you're in, supply and demand factors into this. Uber niche down roles may be harder to come by, but there's not many people who can do it. So the supply demand may weigh in your favor that you get paid more. And that's what I found too in my research, is that the more specialized you are, the more you get paid. But then on the flip side of that is the more desirable jobs that everybody wants to do, the supply and demand does not weigh in your favor and you get paid less. Another caveat, private practice. Private practice is a totally different animal than organization-owned provider groups. And I think I also did a blog post where I talk about the difference in employment structure between NPs and RNs, because they're very, very different. As an RN, you generally work for the hospital or the clinic or the organization, if you will. As a mid-level provider, you are working for generally a physician group or a hospital admin group that is separate from the hospital, not owned by the hospital. So I don't get a paycheck from the hospital system that I work for. I work for a physician group. So it's a little different. And those kind of groups are still, though they're highly structured, lots of CEOs, VPs, that kind of thing, everything is pretty standardized, if you will. Versus if you go to work for private clinics or private organizations, whoever the CEO of that company is dictates how it's going to work. And so what I find in the people that I talk with is that some people that work for private clinics will make a ton of money because they work for someone who values retaining staff and paying them well. And then others are the complete opposite end of that. You know, it may be a physician or somebody else, some administrator that doesn't value retaining staff and just wants a warm body and pays like crap. So it's sort of all over the place in regards to that. So that's a different kind of thing. I work at the hospital, but not for the exactly. Same here. Also, another caveat is this. When I get to the second list where I give you numbers, the median roles, and there are, I think, 15 or 16 of them, those that fall in the middle are all like neck and neck, and they may only be off by like $1,000. So is number 8 really number 4 or number 6, number 10? So it's all really, really close. So that's why you're going to get all over the spectrum. Like if you talk to people in real life or on the NP forums, you're going to find that one critical care NP in one place makes a ton of money and another one somewhere else doesn't. I mean, it's just makes more than another specialty. So it's all very, very close. These are broad generalizations. But again, I think important because if you're making a decision about going back to school, money, none of us want to work for free. So it matters. It does matter. Is it the most important thing? No, you just start with your passion. But then go to what will give you the best work-life balance that you need to meet your income. Okay, so those are all the caveats. So let's do the first list, which is top earning APRN salaries by field of study from most to least. Okay, y'all, some of these really surprised me, So, all right, I'll just save all the commentary for as we go through it. But I am talking about all different types of APRNs. So advanced practice registered nurses. So not just nurse practitioners. So anybody want to guess what's top of the list as far as specialty goes? It's what every ICU nurse is wanting to go back to school for. Well, not every, a lot of them. I run into a lot of ICU nurses who are only in the ICU because they want to become, that's right, CRNAs. I got no shade to throw at them though, because holy crap. Okay, these are a totally different type of provider, y'all. They are not nurse practitioners. They are nurse anesthetists. They have their own school. It is completely different than our school. I know some CRNAs, but obviously I haven't been to CRNA school. So I don't want to speak out of turn, but most of them, it's a 3-year program. You have to be in there full time. They're very hard to get into. They cost a lot of money, but they will also pay you a lot of money. And my gosh, speaking of the locums, if you're a locum CRNA, holy mackerel, will you make a lot of money? And I'll get to there on the next list too. So I'll talk about like specific numbers in the next one. Number 2 would be the psych mental health nurse practitioner. They make bank. Yeah, they do. But you got to sit like in a cold OR room. I don't think I would like it. I need to be mobile. I need to get up and move around, and I need to like talk to people. I mean, I know there are people in the OR room, but I don't feel like I can do it. Okay. Distractibility is high today, friends. High. We have progressed beyond the point where I share with you what makeup I'm using. I know y'all are devastated by that. It's the same stuff, though. No surprise here. Oh, by the way, though, last week I did talk about this new cream or whatnot, because rosacea is also a running topic. Is there a National Rosacea Society? They should sponsor me. Plexion, this stuff, which was a freebie that the dermatologist gave me. This is life-changing stuff. This is not what she prescribed me. I'm actually on 2 other creams that maybe are doing pretty good. But I had this for a week before. Yeah, because I just got my meds yesterday. Y'all, it's already clearing up. Like, what? I have terrible rosacea. It's bad. Okay, squirrel. Hello, Ronil. Glad you could join too. This is where we talk all things random makeup and nurse practitioner stuff. Today we're talking about money, the good one. Okay, so psych, mental health, nurse practitioners, holy mackerel. I heard somebody say literally just today that they feel like this field is starting to get a little full too. I haven't seen or heard that aside from this person who said it today, and it was on a podcast. I don't know how true that is. I don't know if there are any psych people on here, but if you have any sort of desire to be a psych mental health nurse practitioner, go do that, because I'm not entirely sure I feel that that's true, that it's saturated, because particularly post-pandemic, what does the world need? More mental health. And just like in like what I've seen in practice, it is so hard to get in with a mental health provider. There's like a wait list forever long. So I don't know, maybe that's just specific to my region of the world, but I doubt it. They get paid very well. And that's not if you're not going into like opening your own clinic. You have the ability to open your own clinic. You work telemedicine from your own home. They do well. Number 3, neonatal nurse practitioner. This one is going to belie everything I just told you, which is that super, super niche, ultra specialized. If you're a neonatal nurse practitioner, that's what you do. You take care of neonates. But I was told this when I was in school at Emory. They told me that NNPs make a lot of money, and that's what I see too on the forums. And I'm gonna tell you specific numbers when I get to category list number 2 also. But they make money. NNP in my lifeline, 11 NNPs. Yeah, they. I feel. Talk about pressure. I would not. I couldn't. I'd cave. They're just so little. The little feeding tubes are little airways. Oh my God, look at these little ET tubes. They're just horribly small. I think I started to say if we ran out of time, we might talk about something else. And one of the things that was on my mind was intubation, but I don't know if I actually got those words out. Maybe we'll talk about that later. Maybe we won't. I don't know. It's all a big surprise, right? Okay, after that is, interestingly, emergency nurse practitioners. This one surprised me. Scott, you'll be thrilled to hear this, but this surprised me. I don't know if you're wanting to do ENP or not. But here's the thing that's weird about ENP, and I'll go into a little bit more detail when I talk about them on the next list as well. Does that mean ENP as an FNP, ENP as an acute care NP, ENP as an ENP? Does that mean that you're working nights, days? Like, what exactly does that mean? If my body lets me, I'd love to do ENP. Oh, your body will totally let you. It'll totally let you. The patients will abuse you, but it's way easier as an NP than it is a nurse. You don't kind of lift and pull and turn and do all that stuff. But yeah, I was very pleasantly surprised to see that ENP's ranked higher on the list here. After that is the acute care nurse practitioner, and I include both peds and adult here. Number 6 is women's health nurse practitioner. And number 7, Mr. Midwife, why are you so low on the list? There's only 10 here. You're number 7. Why? Why are my midwives not paid as well? And I will get to specific numbers, and we'll talk about what I see here in Georgia. And I hope and pray that it is better where you're at, but very depressing stuff. I don't know if that's just because it is such a desirable field and people want to do it. I don't know, or it's just, I know in my personal life, like I had multiple different midwives and had babies. And over the years, they cut back on how many midwives were at that practice. So I don't know what that's about. But yeah, made me kind of sad. And then family nurse practitioner is number 8. Number 9 is the adult gero primary care nurse practitioner. And number 10 is the pediatric nurse practitioner. And these are all, y'all, these are just my opinion from the research that I did. These are just broad classifications, because I think if you're kind of like just starting your journey of trying to decide to go back to NP school and you don't have any clue what any of them make, it helps to at least have a generalized idea of sort of what pays more than the other. And some of these are kind of close, but obviously number 1 and number 10 are going to be worlds apart. So anyways, hopefully that's helpful. Is reimbursement lower for L&D? I'm sure there's a big chunk of the biz that's uninsured. That's probably true. Although, I don't know, in my work experience, the L&D department is one of the income generating parts of the hospital. Critical care is not. We're the money suckers. Nobody reimburses for that. Nobody pays their bill for that. So I don't know. Maybe it's region specific in regards to that. It's a good thought. Okay, so the second list is top earning APRN salaries by subspecialty. Some of these are like subspecialty, like super specialties. And there are 16 of them, 15, 16 of them. I don't know, I lost count. Number 1 is not CRNA. Now I included all different types of APRNs on here. It's mostly NPs though. It is not the CRNA. Any thoughts on what else would earn more than a CRNA? I find this really interesting. Where is the product that I need? I have no idea. Not nursing instructor. Oh, that's for darn sure. They're not even on they don't even rank. That is a passion project for sure. For sure. It is going to be the private business owner. So practice owners, which I love the idea that as an NP, we have the ability to open our own practice in most states, not Georgia, because we're the Bible Belt. I think we're probably the most least progressive state in the nation in regards to allowing NPs to practice. But most of them, over half of them, I believe at this point, will allow NPs to open their own practice without a physician collaborator in certain specialties. Some of them have restricted, you can, but there are rules and you have to ramp up to it. But if you guys don't know of a podcast called the Elite NP, the Elite Nurse Practitioner Podcast, is run by a guy named Justin Allen, who is a practice owner. He has multiple different practices. I'm fascinated by this. One day I think I want to open my own clinic, but maybe that's a pipe dream. I don't know. Because Georgia. But yeah, these people, 7 figures, upwards of 7 figures. Some of these people, started listening to one today. She's got 4 practices. She lives in Mexico and she has 4 remote practices here. She's psych NP. What else did she say? Psych, and she does psychiatric and weight loss. Yeah, these people are doing real well. Salary is one side of the equation. The cost of your program is the other. The overarching question is, ROI, particularly if you're older. Now, I was 40 when I graduated school. So I was 37 when I was looking at schools. And I was like, do I have enough years of practice left in me in order to pay back this loan? Yeah, it's a big consideration when you're talking about a big amount of money. California just passed a law to allow NP and independent practice. Did they? So I feel like California is one of the more restrictive ones, but maybe they've just recently had some changes. I hope they have. But yeah, so that's number 1. First thing you should do, first thing you could do to make a lot of money is open your own practice. Second thing is CRNA. Now, CRNAs, okay, this is one where we'll talk about numbers. CRNAs, the national average, 225,000, which surprised me because I have seen and heard much higher than that. So again, I don't know if this is because, are they working night? Is there a shift differential that people are talking about? Is there extra pay for extra days? Do they get call pay to come back in? It's just a lot of variables that I think aren't really defined by this specific number, but this is the average from the multiple different websites that I looked at. Georgia specific numbers were 201,000. What? That's crazy to me. That seems so low on ZipRecruiter, and 152 on talent.com. Both of those in Georgia. So what is it really? I don't know. It's pretty high on the spectrum though. My cousin's an MP in California. She told me yesterday. AB 890 took effect January 1st, 2020. There's a path to independent. Okay, so this must be one of those where you practice for a couple of years with a collaborator, and then once you've proven that you've done so many cases or spent so much time doing it, then you can apply for independent practice. There are some states who are doing this. Great. Would love if Georgia will never. We will be the last state. Hey, it's me. I'm glad you're here today. One of the main reasons they chose UAB is the cost factor. No student loan here, working those COVID shifts paid off. That's great because that's still not a super cheap school by any means, but it is a good value school, and I always promote good value schools to people. Very up on the California happenings. I'm sure he is. He knows all the ends. I try and keep my nose out of legislative stuff and academia. Rebel here. It is compared to Emory. Yep. Mm-hmm. Everything is cheaper compared to Emory. I think the only thing that costs more is maybe like Harvard, maybe Vanderbilt. I don't know. It's ridiculously expensive. For me, it was worth it. But anyways, I stay out of running a business. Yeah. I kind of have a little bit of that itch. Okay, so that's CRNAs. Also, if you're a locum CRNA, yeah, you can make 300K easily. And then the primary mental health NP, national average 143,000, Georgia specific 156,000 on talent.com. So here's the thing about mental health NPs. You have a lot more options. You could work from home. You could open your own practice real easily. The laws around treating mental health via telehealth is very low. Words, you know what I'm saying? Easy entry. Not a politician. Yeah, no, I'm not either. Not either at all. Somebody mentioned to me last year, maybe I should consider throwing my name in the hat for being a lead in my group. And I was like, listen, I'm all for tooting your own horn and saying what you're good at, but I'll tell you, filtering my words is not high on the list for me. So I'd just make everybody mad if I was in a position of leadership. So I just do things on my own. Liberal. I like legal stuff. I think that's great. We can sidebar anytime because I don't like any of that kind of stuff. I just get frustrated. It honestly just frustrates me, particularly when it comes to nurse practitioner regulation. I get very frustrated and I don't see a solution for it. And so I just come on a public forum and talk about it. At least I'm not a complainer in private. I complain in public. Okay, so moving on. Okay, number four. These folks, so cardiothoracic surgery or CVICU NP, they make a lot of money. And the numbers I'm going to report to you are not actually what my friends who work in Georgia report making. They report making probably 30 to 50,000 more than this. So I don't know that these numbers are true reflections. What I know is my experience from what recruiters have told me and the people that I know. This is a uber niche specialty, right? Many of these NPs, okay, so there are different roles you can work in this. You can be outpatient in a clinic setting. So you could be FNP, you could be acute care. You could be seeing the pre-op patients, post-op patients in clinic. You could be in the hospital seeing the pre-op, post-op patients. You could be managing the fresh hearts in the CVICU where they're super sick with a lot of responsibility and a lot to manage there. You could be an RNFA and be in the OR harvesting vein. Not a lot of people can do that. Not a lot of people can do either of those things. So the more specialized you are, the more in demand you are because ain't nobody can do it. So particularly when it comes to locums, if there's a place in Florida that has 2 or 3 cardiothoracic surgery NPs that are out, they have to have someone who can do that or else the OR shuts down. So they will pay. And I know this because they keep recruiting me, even though I am not a CT surgery NP. I don't go to the OR. I babysit their patients where I'm at. I know enough to get by. I know enough to manage these patients, but I should not be going to a hospital where I'm not employed. But the locums, my God, the locums that will come after you and sell you on the fact that, you can do this is high because they make a ton of money. So okay, so let me get to the numbers. So national average 142,000, which I think that is low. I think that's a low ball. Georgia specific 130,000 on talent.com and 120,000 on salary.com. Again, my friends here say add 30 to 50,000, which I think is probably true. So the recruiters that were calling me for it, they were like, I think I said some astronomical number. I was like, I don't really know that I can. I mean, I'm critical care, but I'm not really that kind of critical care. I don't know that I can do that. What exactly do they want me to manage? And they told me, and I was like, I just gave them some like super high number. I think I told them initially like 130 an hour, just because I wanted to leave me alone. They did not bat an eye. So they would pay a lot more than that. So you can expect 150, 160, 170 an hour. I don't even know, but a lot. So if you have a desire to do that, you can make money. Now, what I don't know is what hours are you trading to get this salary, because many of them work 9 to 5, 6 days a week, take a ton of call, come in on the weekends. Like, it may be a lot of money, but you may be working a lot of hours to make that money. That's the only thing. I'm not entirely sure. I have no filter. I love people who have no filter. No frontal lobe means you are fun at a party. Half a martini, I'm going to tell you whatever's on my mind. We're going to go dancing. And we're going to laugh a lot. Everybody's going to be my best friend. It doesn't take much. Okay. Number 5 are my NNP friends. National average 133,000 and Georgia specific 118 to 139. Yeah, I don't know. Although, and I guess I do see postings for this. This is one where it is very, very uber niche, but I do see job postings for it. So I don't think it's a supply demand issue, which is something you can run into in these very specialized type of specialties, because people go into it and they stay in it. Yeah, I'm a lot of fun at a party. I mean, I'm high on life too. My kids are always like, Mom, how much have you had to drink? I'm like, I haven't. This is just me. This is just me in real life. Okay, I think I need to do some eyes here. What time is it? No, we're doing fine. What color should we do tonight? I'm not entirely sure. Maybe I will do, instead of my makeup geek, yeah, maybe I'll do some pinkies. I think I'll do some pinkies. I think so. How about, yeah, let's do, struggling a little bit today, y'all. The indecision factor is real. Maybe I'll do this one, like light. I think I'll do this one. Linda from Bob's Burgers. Mommy doesn't get drunk. She says, exactly. And that's probably true too. I almost never make it to the drunk stage. There's perpetually stay tipsy until it ends. And then it's an old Irish goodbye for me where I'm like, I need to go to the bathroom. And then I just disappear and I'm in the bed because I've had enough. Because honestly, you'd think I'm an extrovert, but I am really, every personality test I've taken my whole life has been split right down the middle. I am 50% introvert and 50% extrovert. And I think that's because people who are a little bit introverted, who like to be extroverted around the right people, have their energy completely drained. And then they just, when they're done, they're done. They're done. They can't entertain anymore and they're done. So that's me. We used to have a lot of bonfires in the neighborhood at our neighbor's house, and I was the worst. But I had to put the baby to bed, and then I'd go to bed too. It'd be like 9:30. I go hard for 2 hours, but it's gonna be a fun 2 hours, friends. I'll entertain you. Same. I'm an introvert, extroverted. They're the best people. The best people. They're the most fun. Okay, next stage. All right. We were up to ENPs and the numbers for ENPs. All right, here you go, Scott. National average, 127,000 with a range of 116 to 141, which to me is a big range, which is why I included the range on here. Here's the thing. Is that because they are doing night shift? Is there a differential? Is it because they are getting an RVU bonus. Many of these sites, so what I did was I went on these sites and I searched the averages in each specific field. And then what I did was went through and looked at the post. And so some of the posts will say experience required. So it tells me that this is more for someone who has several years of experience. So it's a higher base rate, I guess, based on that. But the averages, almost all of them said that these were self-reported numbers. So if these are self-reported numbers, are these people reporting that this is my salary, like base plus a bonus or shift differential, or is this just the base? I really don't know. What I do know, and that's why I rank them kind of higher on that, like the first list, is that in general, ENPs fall a little bit higher on the top end of the pay for this. The cool thing about ER is one of the few fields you can go into even as a nurse practitioner, not just a nurse, and they have different schedules. You have the option to do off shifts, which I loved when I did ER, 11 to 11, 3 to 3. You can work. Most places will let you work different amounts during the week. So it's not like a 7 on, 7 off if you don't want it to be. They just want that whole field. So there are a lot of options for you. The other thing that I think makes things a little bit confusing for ENP pay is, are they paying you as an ACNP or as an FNP? Are you doing fast track, or are you doing the more like aggressive resuscitation rooms, which is that a different skill set? Does it pay differently? As an example, I got offered a job in a clinic as an acute care. And because they knew I could run in the hospital, they offered to pay me $15,000 more just because I had that capability that my FNP colleagues wouldn't. So is that why? I don't know exactly. I would be interested to compare ENP salaries with both EDPA and EDMD. Well, you know, ER docs are making a lot of money. They're making, I don't know how uneven this is. ED docs are making a lot of money, a lot more than we are. You know, several hundreds of thousands of dollars, 2, 3, maybe even more than that, depending on the shift that they're doing. Way more than a nurse practitioner is making. And then PAs, I think most places that I know of, PAs and NPs are really pretty much the same. They'll call them APPs, advanced practice providers, or some people will still say mid-levels, but they're pretty much the same. The PAs I work with get paid the same I do, which is interesting because their training is a little different. But there are pluses and minuses to both programs, right? I think that NPs offer something that PAs can't, and vice versa. I think PAs offer some things that NPs can't. NPs or PAs get a rotation in the OR. We don't get that. Most of them get a cadaver lab. We don't. They have more required hours, way more required clinical hours, but that's because the assumption is, as an NP, you've spent hours at the bedside, which isn't always the case. But the other thing is that I find interesting about the NP-PA thing, and I'm going to be interviewing a PA on my channel recently because I got slack from a subscriber that I didn't have any PAs on, and that valid argument. So anyways, I'm going to have her talk about like how her training differs from ours. Y'all, I'm on the struggle bus today. I don't even know what I'm doing here. All right, let me stop for a minute and figure this out. Purpley, maybe? Possibly. The eyeshadow is always the hardest part. Gotta focus or else it's gonna be a mess. Don't even get me started on trying to draw in some eyeliner, which I did the other day and it turned out really great. When it turns out great, it is so pretty. But my God, the pressure. One wrong move and it's like, you gotta start all over. Don't know that I'll be doing that today. Okay, now I can do, no, I can't do that yet either. Should I take my Adderall today? You're welcome, friends. You get to watch the Psycho Fest that is Bree trying to multitask. Don't forget to take your intubation lipstick. Oh yeah, and we were going to talk about intubation too, which I don't even know if I'm going to get time to now. Next week's like clinical topic is going to be ABGs versus VBGs, how to compare them and how to read ABGs, which is, you know, I think it's a great topic and easy to talk about, but it's not super content heavy. So we may get into some talking about intubation, which I could talk about all day long, because I think there's a lot to talk about when it comes to intubation. So maybe I'll start some of that if we 3:43. That will have time. Okay. All right. So where are we at now? We are at ABGs are one skill I can do. I know there. I remember as a nurse, I didn't know what I was doing. I really didn't. But you know how like you don't want to admit that you don't know what you're doing, so you just kind of like fill in the blanks like a dementia patient. So you act like you know what that ABG meant, and that you're interpreting it, and you don't. But I remember this one time a pulmonologist asked me years ago. This was when I first started in ICU, and she was like, "How'd that ABG look?" I was like, "It looked like crap. It looked so bad." And she picks up and looks at it. She's like, "It doesn't look bad. What are you looking at?" And I was like, I don't know. It took me a minute. Y'all. And I had been an ER nurse for 6 years. Not a brand new nurse, but I just didn't really spend any time figuring it out. But once you do figure it out, it's, to me, anything that has an algorithm, I love, because you can teach it to yourself. And it's just repetition. You do it over and over, and eventually you get it. It's very like objective. So I think ABGs are cool, but I have a lot of pet peeves about ABGs. I think we get too dang many of them in the hospital, and it frustrates me. So I am constantly asking my students, and even plenty of the nurses and RTs at the hospital, like, why are you? Tell me why you want an ABG, and then I'll tell you yes or no. And a lot of people can't tell me why, and that's my only thing. Is just understand not only how to interpret them, but what they mean, how it's going to change your management, and whether or not you need it or not. I think we get way too many ABGs. That's me. I don't know ABGs. Yeah, if you don't got to do it, I didn't have to do it much. So I didn't spend time learning how to do it. It's not hard, but once you get it exactly. So relatable, right? You're like, oh, it looks terrible. I don't know why it looks terrible, but it does. Why? Just to cover you in court? Well, no, I think it's that. So here's the thing. I think that a lot of things are protocol driven. I think that a lot of times, in particular, you think about the rapid response team, they are generally nurse led and they operate on protocols. So they will go in and it's almost like every single rapid response call, they get an ABG. If it's not the nurse, it's the hospitalist or somebody else, one of the other providers. They've just got an ABG just because. And I'm like, if you can't justify to me why you're getting it, you're just ordering a bunch of stuff, hoping that you'll find something abnormal. And then what are you going to do with it? So I always want to talk to, always with new providers and NP students when they are rotating with me, like, think through what you plan to do with this test you're ordering. Even if it's something as simple as a CBC, why are you ordering it? What are you looking for? Is it just to check for things? Maybe you don't need it, That's just my thing, is that I don't mind them. I just think we get too dang many of them. True that. Protocol. I know. Protocols. Now, they exist for a reason. They do. And I understand the reason. It's just that when people stand on ceremony with the whole, I've worked in institutions where everything is heavy protocolized, and the nurses will get like, well, I'm going to write you up if you don't do this because it's not protocol. Well, okay, but let's think through why it is a protocol. Let's just talk through it. If you can explain to me why we need this, by all means, get it. Tangent. A little bit of a pet peeve. See again, why would I be in leadership? Okay, so we talked about ENPs. Number seven is cardiology. Cardiology specialist. Now these next, I would say numbers 5 through 10 are all neck and neck, right? And you're going to get some differences because of all the reasons we've already talked about and why one cardiology ENP will get paid way more than another. But the national average for cardiology, just the generic term cardiology NP, when you search it, that's what you get. 126,000. Georgia specific is pretty close to that, 120,000 on salary.com. But here's the thing, cardiology is a massive field for providers. You can work inpatient, outpatient. Within each of those, you can subspecialize. There can be a heart failure clinic. There can be a hypertension clinic. There can be an EP clinic where there are electrophysiological problems. It can be a structural heart team. It can be cardiothoracic surgery. So many different types of cardiologists because most people have heart problems. That is the number one problem in America, right? So lots and lots of providers. So, and that's just clinic. You have all those same subspecialties inpatient. So are you inpatient or outpatient? Are you FNP? Are you acute care? Are you adult gero? What is your certification? What is your role? Like, how many days a week are you working? Are you taking call? I think there's a lot of variation in how much cardiology NPs get paid. And so I don't know what this 126 is representing. I have no idea. But I do know that in general, most cardiology teams will pay a little better. It's not always the case. The other thing you kind of got to look at is the size of the group and the turnover. One of the things I always advise cardiology NPs in particular when they are interviewing or looking at a group is ask them what their retention rate is. Because cardiology, because it's such a big field, there's always openings. So you get a lot of new grads who go straight into cardiology, and it may be a good work model or it may be very toxic. And so in my experience, cardiology tends to be a churn and burn type of field. Bring in a lot of NPs, burn them out, and then rotate through it. So they're always hiring. So I think a key factor in determining whether or not a cardiology group is a good place to work is to just outright ask them, what is your retention rate? And they probably aren't going to know, but it'll tell you something. So another thing I wanted to point out about cardiology was that I looked on, where was it? Glassdoor. Okay. One website, same website, Glassdoor, the average for cardiology NP was 116,000 in 2019. But in 2022, just 3 years later, it was 139,000. So same state, same website, massive pay increase. So is this because the field is growing? I don't know. I don't exactly know what that means, but it's just something to consider. Mr. Midwife said, I did not go into cardiology. I just didn't have the heart for it. That was a dad joke. That was very well done dad joke. And I'm giving you a lot of credit there. Okay. But same. I don't mind cardiology. I used to not like it at all, but I don't mind it at all. It's complicated. I think that's why a lot of people shy away from it. Okay, so number 8 is hospitalist or other inpatient specialties. So, okay, so and critical care is number 9. So we're off by, I think, $1,000, these two. So which one is more? I don't know. There's a reason why I argue that critical care should probably be higher than hospitalist, but a lot of variables here, okay? In general, the hospitalist teams that I see work 7 on, 7 off. So they work a lot more shifts to make that same salary. But the numbers I saw, the national average was 120,000 on NP Hub and 155,000 on Glassdoor. So I didn't put an average because those are two big differences to me, real big differences. I think that in general, they get paid pretty well. And I think a big part of that is that most hospitalist NPs are working at night. And they may be in a critical access hospital where they're the only person there. So they probably can command a little bit more salary. What else do I want to say about them? Oh, and then and I lumped in other inpatient specialties. Now, you're going to get such a wide range on what will be paid for this, but you also have to look at how much you're working to how much you're making. So like if you go to work for like a GI group that's working in-house, you are most likely going to be working on a model where you get a census of however many patients you need to see during that day. And once you're done seeing them, you can kind of leave. So it may be a very short day. And even though your salary may be a little bit lower, you're actually working less to make that same amount of money. So apples to apples, is it really less? Maybe not, maybe even more. And versus there are others where, you may be required to do a 12-hour shift, or you may have a case where you have a certain number of patients you got to see and you can't leave until these extensive procedures are done and you have to stay late for them. So you kind of got to feel things out when you're interviewing. This is definitely the one that I would ask for a shadow day interview. Any kind of inpatient specialty, I would ask for a shadow day because you want to see what their actual working relationship is like and how much they actually work to make that money. You have 6 kids? Wow. I did not, and the dad jokes continue. And they continue. All right, where are we at now here? I think we are at the point of drawing the eyebrows back on. Okay. All right. So we talked about that. In critical care, the national average I saw was 115 to 150,000. I think the 150,000 I saw on Glassdoor. No, I'm sorry. 115,000 I saw on Glassdoor. NP Hub says 150. I feel like it's probably closer to that 150 mark for national, because I know what our kind of local numbers are. And I know what most people get paid around here for critical care. A lot of that, most critical care jobs I know around here at least work 3 days a week like nurses do. So you're not working as many shifts per year. I think it ends up being like 144 a year versus like 150 something if you do 7 on, 7 off. So it's a little better work-life balance for the same pay. So overall, it ends up being more pay. Also, there's usually a pretty decent shift differential for nights. And then some places will pay overtime. Mine doesn't, but some do. Or they'll have like critical pay dates where they're super duper short. My wife is really in love. She knows how she gets pregnant, right? She does know this. I'm sure she does. She's married to a midwife. That's what it is. You just want to keep delivering the babies. Trying to single-handedly repopulate. Keep your business alive. Primary care is next, all right, at national average of 124,000. 124,000. I was kind of surprised by this one, and I was pleasantly surprised. And the reason I was surprised is because I feel like a lot of the clients that I get are primary care. They are in a spot where they are not in a good work environment, and it has affected their desire to continue with the profession or change their opinion about what they're capable of. A lot of different reasons why people are coming to me about career advice. And so I have a little bit of a tainted view towards primary care because I think that they are, in general, very abused. I think that they are worked very hard. I think the work in and of itself is very hard. I think that they're probably not given enough administrative time during the week. So many of these people are working straight through their lunch break and still staying late at the end of the day. And they have an in basket they have to fill, complete once they get home. Reviewing, there's just a lot to it that they don't get reimbursed for. And if you have low pay to high amount of time you're working, to also then working with a team that doesn't feel good or doesn't make you feel good, doesn't support you or train you properly, it's a recipe for disaster. So I'm a little bit tainted towards primary care. I was kind of pleasantly surprised to see this national number and even the local numbers. So on salary.com, I saw 118,000 for Georgia. And on talent.com, I saw 113,000 for Georgia. And that is not what I see on the job boards. On the job boards, I see like, $45 an hour or 80 grand a year. I mean, these people are probably the hardest working NPs of all of our profession, and they get paid the least. It's very depressing to me. But I don't know, somebody chime in that maybe works in primary care that's happy with it, that doesn't have that experience. I would love to talk with you. And find out what the secret is for, reimbursing you properly and keeping you happy. Okay, so that is number 10. Number 11 is surgical NPs. National average 114,000. Georgia specific 125 on talent.com and 112 on salary.com. I don't really know. I mean, I know a few people who work in this field. I think that it could be a great field to work in, or it could be really exhausting. I think the people who do it are the people who really like to be in the OR. I wonder if this salary includes, requires you to have an RNFA, and are you like in the OR operating, or are you just doing post-op rounding? Are you doing clinic, kind of like the CT surgery thing? Like what exactly is the role that's reimbursing for that? Because I would think if you're able to do all of that, I feel like you would be able to command a higher salary. In particular, I mean, a lot of these people, if they're working in OR, they take a lot of call. Should be paid a lot more than that. Nicole Cochran says, thank you for sharing this information in one place. I'm an AGA CNP student graduating in May and applying to jobs. I love your content. Thank you so much, Nicole. I'm glad to have you here. Do you know what you want to do yet? May, it's right around the corner. I have a student with me. I have two students with me this semester, actually, that going to be graduating in May. One of them's got some experience. One of them will be a new MP. I always love to see where people end up. It's just really interesting to me. Whew, this is rough today. Whew, the mascara's not laying down well. I feel like in all these videos I say, good thing it's at night. Okay. Okay, number 12, this is midwife. Coming at number 12 out of like 16. Again, national average 108,000. Dude, 108? That's just not right. Georgia specific said 114 via salary.com and 97 by Indeed. I don't know if this is just because people want to do this. Okay, the caveat to this is this. Okay. I think a lot of this depends on where you live. I saw a posting in West Virginia for a midwife that was like 163 or 4,000. And I saw one in California, like Northern California, it was like 135 or something like that. God, you're at 115. Does that include, I mean, I know you said you're salaried. I'm sure you have to take call, right? Or is it just you work your shift and whatever babies come in on your shift, you're there? You don't go home and then take call and have to go back? Because to me, that's a whole different animal of messing with my work-life balance. But West Virginia, here I come. Yeah, except they're going to be, well, I won't say anything. It might be bad. I won't say anything bad. It's just going to be a poor income area. So it might be hard. It might be kind of hard. People coming in with no maternal care and stuff like that. Hours plus call. Dude, that's rough. Neurocritical care would be my dream job. Okay. Neurocritical care is a very interesting field, and we actually just started neurocritical care ICU at my hospital. One of my students from last summer just took his first job in neurocritical care, making very good money. Now he's working nights, so it's like 3 months. He'll ramp up to 3 months on days and then a month on nights orientation, and then he'll be on his own. But still, starting salary there in this neurocritical care ICU here in Georgia is what I made probably 3 or 4 years in, doing extra shifts, picking up some nights. Most places hire, in general, y'all, most places that, in my experience, when they're hiring, these are organizations hiring, they're going to be fairly standardized. So they're going to hire you in at a certain base rate if you have less than 5 years experience. Then if you have between 5 and 10 years experience, they're going to pay another like 15,000. Then if you're 10 years or more, they're going to pay the top amount, and that's going to be your cap. But that doesn't include bonuses, and it could be an RVU bonus. It could be a quality bonus, which is what I get. But it tends to be a pretty significant amount once you take out taxes at the end of the year. So these are base rates. But anyways, neurocritical care could probably be a pretty high paying sub specialty. Yeah, sub. Tooth to tooth, tooth to tattoo. See, I didn't say it. So as long as somebody else said it. I was going to say, do y'all remember that movie Winter's Bone with Jennifer Lawrence? Wasn't that West Virginia? Where I feel like it was, where she was, oh my God, that movie was so good. I don't want to give anything away if you haven't seen it. If you haven't seen it, I think she won an Oscar for it. It is fascinating. What can I say without giving it away? It's just fascinating. Go watch it. But I think that was West Virginia. So that's, I think, the picture I have of West Virginians. Maybe that's why they pay so much to reproduce. I don't know. Okay. So we talked about, in general, you're going to make more if you go somewhere very, very rural, West Virginia, California, like outside of California. And okay, number 13, aesthetics, which is what everybody wants to do. National average, 106,000. Nurse.org gave me a range of 91 to 123, which is kind of a big difference. The postings I see around here are not even for that. They're like not even 6 figures. Because I think they know they've got a corner on the market. Like everybody wants to do it because it's happy work. Everybody's happy doing it. So they just lowball them. People just want to get into it. Georgia specific, 90 to 100,000. Around 90 to 100,000. But again, some of the ones I saw were as little as 80,000. That's also assuming you don't work for yourself or have your own clinic, which might be the way to do it. Um, okay. Pediatrics, number 14. I think it's because everybody wants to do it. It's a supply and demand thing. This is one where I saw literally all over the map the numbers. The national average ranged from 84 to 105,000. Nursa.com gave me 113,000 and Glassdoor gave me 142,000. Those are all national numbers. So 84 to 142,000, I have no idea. And I have nobody that I know that works in peds, so I don't know what they make. I also don't know, I'm assuming this is outpatient because acute care peds is a different animal. Outpatient specialties comes in last, and this is just because I didn't really know where to put them, but some of them are incredibly low paying, and it just breaks my heart for our profession. Like I saw a dermatology position that was 98,000. I saw an endocrinology position that was 89,000. These are both Georgia numbers. So I think it depends on what specialty it is that you're working in, whether it's private pay or organization owned, all those kind of factors. So that's all that I had on there. I really should have included women's health somewhere in there, and I'm not sure why I didn't. I think because I almost never see job postings for women's health. I feel like that's one of those specialties that like people get those jobs and they don't leave them because I don't think there are a lot of them. And I think people that do that kind of thing, God bless them, but they want to do that kind of thing. I talked about them in the first group, like the generic field of study, but I don't have specific numbers like in the specialty of women's health. So I didn't include, hold on a second. I'm drawing my lips bigger than my lips actually are. I think that's the thing to do these days, though. I think that's what all the people say to do. Make them bigger than they actually are. Okay, so that's the list of the list I have. PAPs all day long, no thank you. Oh, heck no. That's for sure. When I worked in ER, as the token girl in the ER, you get stuck in that pelvic row because all the rooms with the stirrups in them are all in the same spot. So you always got to sign those 4 to 6 rooms. And my God, all you do is pelvics all day long. Gross. They're not healthy pelvics either. Mm-mm. 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 Nope. Mm-mm. Yeah, this is probably even lower on my totem pole than delivering babies. Mm-mm. That's a no-no. I have had to do 2 pelvic exams in my career, which, yes, they teach you in acute care school because God forbid you have toxic shock syndrome and a retained tampon or something else up in there you got to go get. So we had to do, have I told you all the story before of how traumatized I was in my live guided model OSCE where we had to go in and do it in front of, oh my God, it's horrible. I'm still traumatized by it. I am seriously emotionally damaged. We had to do a man and then we had to do a female, and both of them are paid models. So Emory paid these people, and they made I know the dude got like $100 an exam. So there's a line of 6 people just in my group ready to do an exam on him. And it's just, the whole thing is awkward. And I get it. We need to learn how to do it. It's good doing it on a real person. Only thing is, these models have been doing it for so long that they think they're teachers now. So they want to give you this lecture before you do it. So for the guys, I always volunteer to go first. Or the kids in my group always told me to go first because they didn't want to go first. And I was like, well, the thing about volunteering to go first is that they'll take it a little easier on you. So I was always first. So I'm sitting on a stool and he's standing in front of me, naked from the waist down, holding a sheet, giving me the lecture on what I need to do. And I was like, okay, just get on with it. So he drops the sheet, and we start with inspection. So he has to go through what inspection is. I'm like, oh my God, I'm not a nurse anymore, but okay. I see it. I do not see any irregularities. I don't see any nodules. I don't see anything concerning, no redness, nothing raised. I'm trying to verbalize out loud. And he said, but you haven't fully inspected. And I said, well, I don't know how much more I can what else can I see without palpating, And I don't know if I should be talking about this on live, but I didn't know, okay, I'm a girl, so I didn't know that it was possible to take each end of the scrotum and stretch it out. And it kind of surprised me a little. So he said, you have to stretch it out to look at all the parts. And it scared me to death. And all I could think about was the dinosaur from Jurassic Park with like the, because that's what it did. And I was like, oh my God. And I pushed myself back on the stool and it rolled back. And the guy behind me about passed out. And it was traumatizing. So traumatizing. Mm-mm. I don't want to do people's parts. And the girl was even worse, which I can spare you that story. She was even worse. I was like, I don't feel your cervix. Am I supposed to feel your cervix? Go anterior. I don't want to go anymore anterior. Yeah, no. Mm-mm. Mm-mm. No, not fun. Glad I'm done with that phase of my life. Okay, so we've gone through all the pay. I think when you're weighing, who was it on here that was saying there about fixing to graduate? I think starting with what your passions are, looking at what is available in your region. And before you even do that, like literally sit down and write a list of what matters to you in a job. And pay is gonna fall in there, and it's gonna be pretty high up there, right? Nobody wants to work for free. But list out all the other factors: location, onboarding, how many hours you're going to have to work, all of the things that matter to you, and then really truly reflect on what matters to you the most, and then rank them. And then if you get a better sense for where your salary requirements fall in that ranking, it'll help you when it comes time to looking at what's available in your area. Because it may be a situation where you really, really want to do midwifery but you need to make a certain amount of money. So what you may be willing to sacrifice is location. So you may move to West Virginia. I mean, it's just a matter of what's important to you and your life. And that's not something anybody can answer for you but you. But hopefully, like at least knowing some general numbers will help you kind of hone in on what it is you want to do and what you will be happy doing. Again, money is just a small piece of it, but the traumatizing. It's just a small piece of it, but hopefully it will help you. So I was going to talk about intubation, but I've talked for an hour and 10 minutes. Y'all are probably tired of hearing me talk. So I guess I'll just lump it in next week with the ABG talk. I haven't even written that blog post yet, but I wanted to talk about not just ABG interpretation, but how to convert a VBG to an ABG. And I think it's okay. So I won't go into more. I've already talked a little bit about ABGs, but if you guys have any other questions or anything else you want me to talk about, just send me a message, put it on here, email me, snail mail me, whatever. I am pretty much an open book. So I hope you all have a great night and don't have nightmares from my traumatizing school stories. Thanks for coming in. I will see you next week.